Hello, and thanks for coming. We're going to be dissecting a autopsy heart today and show you how that's done. My name is Dr. Steven Salvatore, and I'm an assistant professor of pathology and laboratory medicine here at Weill Cornell. And I specialize in autopsy and renal pathology.
My name is Ami Patel, and I'm a first-year resident.
All right, Ami, you're going to be doing the majority of this dissection. So here we have a heart, and this is a little bit different, obviously, than surgical pathology. Number one, we don't get hearts on surgical pathology in general. And we also don't get things in autopsy like they're delivered in surgical pathology with a specimen, by itself. Mm-hmm. So we've already done some things prior to filming this, obviously, and that would be removing the organs. So we get the whole body, we remove the organs in an en bloc format. Do you remember what that's called?
Lutil method?
The Lutil method, yeah. Yeah. And so that's been done prior to this. So when the heart has come out, we've dissected off the pericardium. Obviously, there's been a transection here of the aortic, of the aorta and the pulmonary artery. And so we're left with the heart, and we're going to demonstrate what to do with that. So there are a couple different ways to cut the heart. So first, I think we need to know about the patient's history. So can you tell us about the patient's history?
Yeah, so this heart is from a 54-year-old male who has no known history of coronary artery disease, and he died of metastatic carcinoma.
All right, so are we expecting to find much pathology in this heart?
No, it should be a normal heart.
Should be a normal heart, which happens at autopsy. Mm-hmm. People can die of multiple things. This guy did not die of a cardiac death, but nevertheless, we're going to show you how we dissect the heart. It's important to know the history because the dissection will be tailored based on the history. We're going to do the routine heart dissection in this case, which is centered around coronary artery disease. So how would our dissection differ if this were a congenital or a pediatric case? What would we be looking for more specifically?
So in pediatric cases, actually, the dissection differs in a couple of different ways. First of all, we keep the heart attached to the lungs, and this helps us confirm normal anatomy and relationship between the two structures. Secondly, we look for the major valves coming off of major branches coming off of the aorta, so the brachiocephalic trunk and the left carotid and then the left subclavian. We also look to see if there's any coarctations present. One of the big differences is that we dissect the pediatric heart according to blood flow, mm-hmm. and that's to look for septal defects. And then lastly, for pediatric hearts, we look for the patency of the foramen-ovale and also the ductus arteriosus. Versus in a patient that has a history of coronary artery disease or heart hypertension, we usually bread loaf the heart so that we can evaluate the myocardium and look at the thickness of the ventricle. And then also we want to thoroughly evaluate the coronary arteries, so we dissect them entirely and take them out. We calcify them if necessary. Decalcify them if necessary, and then section them at 2 to 3 millimeters so that we can really evaluate the degree of stenosis.
All right, very good. So we're going to do the latter of the two methods. And so here we have the heart in anatomic position. I like to always go back to anatomic position. The one tricky thing about the heart dissection is knowing where you are in relation mm-hmm. to the other the ventricles and atria. So to return to anatomic position is always a good idea, and to keep your bearings straight. So we're looking at the front of the heart mm-hmm. here, and as I mentioned, we have the aorta, the pulmonary artery. The pulmonary artery, of course, has been cut off from the rest of the pulmonary artery, but in situ, we usually make a nick in the pulmonary artery, which is the rightmost trunk, and we do that for what reason?
We want to look for that thrombosis.
Right, a large saddle pulmonary embolism.
Yeah.
So we find that by making a nick here inside the body before everything gets jostled around, we can stick our finger in and see if there's a large pulmonary embolism. So that's already been done. And here we have the anterior surface of the heart. There is one vessel that comes down like this. What's it called?
The left anterior descending artery?
Right, the left anterior descending artery. And that vessel is an actual an anatomic landmark because it tells the difference, the border between the right ventricle and the left ventricle, which is what you see here. If you follow the LAD back up to where it meets the aorta, and we're going to reflect to the pulmonary artery away, but then we can see where the circumflex will come off, and the circumflex will go in this direction towards the posterior surface of the heart through here. The right coronary artery also comes off of the aorta, and it comes off in this distribution, and it also goes along the lateral border or to the posterior side of the heart. And how do we tell if heart is of right dominant, left dominant, or co-dominant coronary circulation?
So the artery that supplies the posterior descending artery is is basically what decides the dominance, the coronary circulation dominance. So if in this situation, the right coronary artery supplied the posterior descending artery, then we would call it a right dominant heart. If the left circumflex, which is a branch of the left main coronary artery, supplied the posterior descending artery, the heart would be left dominant.
Right.
Now, if both left circumflex and right coronary arteries supplied the posterior descending artery, then it would be co-dominant.
That's correct, and most of the time it's
right dominant.
Is right dominant, and I believe that this one is going to be right dominant. The right coronary is coming along like this, but we'll find out because we're going to remove the coronaries to best evaluate them. All right, so return it to the anatomic position, and this would be the patient lying down, their head up here, feet down here. And all right, so the first thing you want to do is to reflect the pulmonary artery, which is this structure here. And the reason we do that, it's normally adherent to the top of the aorta, and we need to get it off of there because our final cut is going to be from the left ventricle up through the aorta, and it's going to be through this distribution. So we need to get this vessel reflected this way and out of the way, or else we'll cut across it. So why don't you go ahead and start with that. All right, so you've reflected the aortic, the aorta away from the pulmonary artery, or vice versa, and that's something that needs to be done for later on. So the next thing we're going to do is remove the coronary vessels, and generally start on the left, but you can do whichever one you want. So you can do it one of two ways. You can start at the end and go up the LAD to where it comes, where it arises from the aorta, or you could go the opposite direction, and you can start at the ostia and go distally.
Okay.
And the reason that we do this is if there is a coronary thrombosis, if we just serially section them, we might miss it. So particularly in the cases of coronary artery disease, we'll remove the vessel intact. That way we essentially can't miss a thrombus that might be in that vessel. So fast forwarding to how the coronary has been now almost removed from the heart, why don't you show what you've done here?
So starting at the left coronary cusp, I dissected the left coronary artery. So this is, this is the main left coronary artery, and it branches down into the left anterior descending artery, and then it comes around here all the way around as the left circumflex.
All right, so you want to complete the removal of that left coronary? So that's the left side of the circulation. And now the right.
So again, starting at the ostia or the right coronary cusp, I dissected away the right coronary artery, came all the way around the right ventricle, and here you can see that actually it's the right coronary artery that is supplying the posterior descending artery. So it's a right dominant heart.
All right. Excellent. So you want to take that off. Now, if these are heavily calcified in a case of coronary artery disease, we'd want to put them in decal, right?
Right.
And save them potentially overnight in decalcification and then cut them the next day. We can't submit them if they're calcified for histology, or they'll shatter. We won't be able to see how much stenosis there is. These vessels, I think, are not as calcified, and so we can cut them immediately and see how much stenosis there is. So again, and as you mentioned, the left main coronary is here. It branches into the circumflex and the left anterior descending. And then this is the right coronary that comes straight off. So you want to serially section them and see if there are any thrombi there. So why don't you go ahead and do that now?
Okay.
At the same time, you want to see how much stenosis is present. We're still not submitting it for histology, so there's a chance, as long as you can cut through it, then we can put it in the decalcifying solution and then submit it for histology after that. All right, so that's the circumflex.
Mm-hmm.
So what would you rate the amount of stenosis of the circumflex?
I would say mild.
Yeah, and so we could do it as mild, moderate, severe, or you can give a percentage. I think, I agree that it looks mildly stenotic at most. No thrombosis, right?
No.
All right, so same thing with the LAD and left main. And so what do you think about the amount of stenosis in those vessels?
Again, I would say mild.
All right. So if you want, we have some cassettes over there. Let's take a representative section, or the most stenotic section of both the circumflex and LAD, and put them in a cassette so that we know. All right, so that's the circumflex.
Mm-hmm.
Is that up? I will label that over here. And the same thing with the LAD. All right, and same thing with the right coronary. Thanks. And are you cutting the proximal end or the distal end now?
This is the proximal end.
And how can you tell that?
So it's a wider caliber vessel, and also it branches
Yeah.
after. So I guess I have a question regarding whether this, when we look at the arteries, are these real clots, or is this just post-mortem changes? And how can we tell the difference?
Well, so there will be blood in the coronaries a lot of times at autopsy. So this dark material in here is probably just representing post-mortem blood that had clotted that's there. On histology, we'll be able to definitively tell because it's a different color of pink, whether it's an acute thrombosis or just stagnant blood. But I tend to believe that this is not actual thrombosis. So that is the coronary portion. And now we're going to return to the heart to evaluate the ventricular wall. So here again we have the heart in anatomic position with the anterior facing towards us. And if this were a case of coronary artery disease, we're worried about myocardial infarct. We want to bread loaf the apex of the heart up to a centimeter or two below the valves. Why do we bread loaf the heart in these types of cases?
So that we can look at the thickness of the myocardium, and also, thoroughly evaluate for ischemic areas, ischemic changes, either pale or hemorrhagic, depending on the timing of the infarction, and also localize like which arteries the ischemic event came from.
Right, so we see more of the surface area of the ventricle. Okay, so why don't we take our larger knife. Here, I'll let you do this.
Okay.
And so you can hold it in any way you want. So we're going to bread loaf the apex for a few slices through here. Yep, that's good. So you want to make them relatively thin. I think that's...
Mm-hmm.
In the first sections, unless the patient has congestive heart failure, generally are going to be mostly left ventricle. If the right ventricle is extending all the way to the apex, then typically you're dealing with someone with CHF. So here we have the apex of the heart that's cut very nicely, and we can see both the left ventricle, which is significantly thicker than the right ventricle in most cases. Can you think of any conditions which the right ventricle would be thickened? Maybe to even the same size as the left ventricle in some cases?
Just if you have hypertrophy of the right ventricle called cor pulmonale, you get hypertrophy of the right ventricle.
Yeah, so generally in lung diseases, the right ventricle can thicken significantly with pulmonary hypertension, and you're right, cor pulmonale is a term for that in some cases. And so we do see that from time to time. This patient, I would say, does not have that, because you can see how thin and normal appearing the right ventricle looks. Okay, so that is the apex. We want to evaluate for any areas of hemorrhagic, either dark red or pale, firm areas within the myocardium. Do you see anything that looks like that?
Nope.
No, so this looks pretty normal. There might be a little bit of ventricular thickening, but no areas of acute or chronic infarction, I would say. And another cause of acute death can be significant right ventricular thinning, which is called arrhythmogenic right ventricular dysplasia. This patient also does not have that because it's paper thin in those cases. And they have a clinical scenario of acute sudden death. So that wouldn't fit with this patient either. Okay, so let's turn back to the base of the heart. And then we're going to, or you're going to cut so that we can see the valves and the remainder of the heart grossly. So the first thing that we're going to concentrate is, we call it as flow of blood. And so we want to start on the right side. So you want to identify the superior vena cava and inferior vena cava.
Okay, so this is the right atria right here.
Correct. That's the right atria.
You should be able to see. The opening to the atria here. Here we go.
Okay, so your left index finger was, I think, in the inferior vena cava, and that's the superior vena cava. So
yeah, this is it right here.
So you want to connect those.
Yep.
Right, so that's the right atrium,
So
down into the right ventricle, but you want to connect the superior and inferior vena cava. So probably, if you go up through here, right?
Yeah.
So here's the superior vena cava, here's the inferior vena cava. And so you can put your finger in there, or you can put something else in there and just connect these two, and that will expose the right atrium. And so these two structures are where the blood is returning to the heart from, in the case of the superior vena cava, the upper chest and arms, and inferior vena cava from the abdomen and lower part of the body.
Okay.
Okay, so I'm going to lay it out. So now we have a look at our first look at the right atrium. All right, and so the next cut is from the right atrium down into the right ventricle, and it should be along the lateral border of the heart. So it's going to be through here. So you can make that cut.
Sometimes I just like to use the probe.
Yep.
Make sure you have a surface to cut on.
And you're going to go out
Laterally, yeah.
All right. So now if we open, and now you can see the right atrium, the upper part of the right ventricle, and we have our first look at a valve. So which valve is this?
This is the tricuspid valve.
The tricuspid valve, right? So 3 cusps. And we can measure the tricuspid valve. Cut these chordae a little bit more so it's more open. You can see the papillary muscles, some of the chordae tendineae, and would you say the papillary muscles look intact? Pretty much intact. So we get a measurement here. And it's helpful if this would bend, but we're going to estimate at about 12 centimeters. All right. So you want to evaluate for any vegetations, any disruptions in the valvular architecture. You see some you have forceps. You pull out the post-mortem clot there. So these aren't vegetations. This is just post-mortem clot from blood that was in the heart when the patient died. Okay, so the next cut is from the right ventricle up through the pulmonary artery. We want to do that from the anterior surface of the heart and along the septum. All right, so again, here's your anterior, here's your pulmonary artery. That's your aorta. So you want to stay along the septum and go through the pulmonic valve up through the pulmonary artery.
So again, using the probe helps to just stabilize your cuts a little bit.
It also helps you to not cut things that are not supposed to be cut.
Right. Just
All right, very good. So now we have the entire right heart open, and you have a look at the pulmonary artery. How many cusps in the pulmonary artery?
There are 3 cusps.
There are 3 cusps. And do you see any vegetations or abnormalities with that valve?
No.
All right, so let's measure. So it is about 6.9 centimeters. Okay, so then we turn our attention to the left side of the heart. I want to bring it back up here a little bit. All right. Not so high. All right, so the left side of the heart, again, just like we did for the right atrium, on the left atrium, you want to open the pulmonic veins, and that'll expose the left atrium.
Yeah. So
right.
they're all
That one's. There's normally 4, but this one is when it came off the pericardium. I think it lost the tissue between the 2. Yep. Right. Open it like that. So now we're looking down into the left atrium. And this next cut is the one that's a little bit, if you read different sources, they'll tell you to do it differently. So some sources some literature will say along the septum posteriorly. Some will say along the lateral border of the left heart. I like to do it right in the center, like 45 degrees between the septum and the lateral border. However you do it, you're going to see the valve, so it's not it's not wrong,
Okay.
but it's just kind of up to your preference.
Do that
So
along
either way, I mean, you could do it over
Okay.
there. My problem with doing it along the lateral border is that'll make the next cut a little bit too close, I think. So
Okay.
that's why I like to give it a little bit more room,
Okay, so
and I do it like
that's
halfway
right.
in between.
Okay.
Yeah.
Let's use the knife. Thick.
Yeah, we continue to cut through the papillaries and the chordae.
Okay. Nice cut.
All right, so now we're looking at which valve?
So this is the mitral valve.
The mitral valve. All right,
Bicuspid valve.
very good. So we want to measure that. All right, and it's about 9.7 centimeters.
Okay.
And any abnormalities with the mitral valve? Any vegetations or
It is a little
calcifications?
calcified, yeah.
Little calcified.
Yeah. Mm-hmm.
So sometimes you can have complete stenosis. You don't see rheumatic heart disease so much anymore, but if you did, generally it involves the mitral valve. You can have a fish mouth deformity, thickening of the chordae, which this case does not. But it is a little calcified, I agree. So we'll make a note of that, but probably not leading to any significant stenosis. And you can see the area of the septum, both the atrial septum, and we're not able to see the ventricular septum as well anymore, but this is where an atrial septal defect might lie, and this patient does not have that. You can also look for a patent foramen ovale in this case. You don't have a probe, but you would look here in this area. So that's okay. Okay, so then the final cut is from the left ventricle through the aorta, and this is where we had to reflect the pulmonary artery. So if you go back to the front of the heart, which we've done, then you reflect the pulmonary artery out of the way, and the final cut is along the septum anteriorly right through the aorta like that.
Okay. Again, just, it's nice to probe a little bit. You see it coming out here. The ventricle is a little thick, so to kind of get a good pair of scissors.
Okay. So that's the last cut, and we see the aortic valve. So in older autopsy, sometimes the aortic valve will have been replaced. There can be significant stenosis. This aortic valve looks, what do you think? Anything abnormal there? I'm going to make sure that the number of cusps are correct. How many cusps?
There's 3 cusps.
3 cusps.
You can see the ostia as well. It's where we took the arteries out of.
Right.
Yeah. So.
And so let's measure it. 6.5 centimeters.
Maybe there's some calcification in here.
Some mild calcification. Okay. All right. So the cutting is done. So now we need to do a couple more measurements, and then we'll take our sections. So we want to measure the left ventricle thickness as well as the right ventricular thickness, and the place we want to do that is 1 centimeter below the atrioventricular valves.
Okay.
So generally it's on this part of the heart, depending on how high you cut, but this one is still going to be over here. So this heart we weighed prior to starting, and what was the weight of the heart?
About 370.
So it's about 370 grams. Is that significantly big? Normal,
No, it's
small?
normal.
It's a normal size heart for a man, yeah. Maybe slightly too large, but the very large hearts can be up to 3 times this size. So the left ventricular thickness should really correlate with the weight of the heart. So we're looking at a normal weighted heart, we would think the left ventricle should be in the normal range. So let's do it. I think it's best to go from this side. So you can see the mitral valve. You can measure about 1 centimeter below. And then the one thing you want to pay attention to is you don't want to measure the papillary muscles, and you don't want to measure the epicardial fat. So if you measure here, we're looking at about 1.4 centimeters. So is that a normal left ventricular thickness?
Yeah. Anything less than 1.5 is normal.
Right. Yeah. Generally between 1.1 and 1.5. So 1.4 is a normal thickness. And the same thing with the right ventricle. Okay, and it's much thinner, right? So you want to look at 1 centimeter below, and again, this is where you can measure a lot of fat and you get errors. So you can see the difference between the fat and the actual myocardium. So if you measure here and don't measure the papillary muscle, it's about 0.3 centimeters. Again, what's the normal right ventricular thickness?
Less than 0.5.
Yeah, so generally between 0.2 and 0.4. So we're right on track. So the next thing we want to do is take our sections to look at on histology. And if we don't see anything focally, then we'll just take representative sections to evaluate the entire left ventricular wall, or at least representative sections of that, and as well as the right ventricular wall. So let's do that now. So what I like to do is pick one section, and I'll go circumferentially around it. So anterior, lateral, posterior, and septal. So whichever one you like the best.
Choose this one.
Sure. Let's move it over here. So go ahead. All right. So you have posterior, and the goal for the section is to get both, all the way from the epicardium to the endocardium, and so you can see the whole thickness. So you want to trim that so it's one. So you need to thin it out a little bit, I think. All right. Okay. And then go all the way around.
There's lateral.
All right, the lateral left ventricular wall. Good.
And now we're getting the anterior.
And this way, if there are any surprises, maybe there's global ischemia or myocarditis or something like that, we'll pick it up and know what part of the heart it's involving. Anterior, and then septal. Of course, if there are focal lesions, something that looks like an acute or chronic infarct, then you want to sample those in addition. All right, and then just get one representative section of the right ventricular wall. All right, so those are our sections. And that's basically it. The slides will come out in a few days, and we'll be able to look at it to see if there's anything microscopically. So to summarize the dissection of the autopsy heart, we remove the heart from the rest of the organ block. We remove the coronary arteries. We section through them to make sure there was no acute thrombus or significant stenosis. We bread loafed the apex of the heart, looking for any evidence of myocardial ischemia or other focal lesions. And then we cut the rest of the base of the heart with a flow of blood, looking for any kind of valvular heart disease or atrial or ventricular septal defects. And in this case, we do not find any because that wasn't the cause of death. But in other cases, that is a significant cause of death. So it's an important portion of the autopsy. So that's it. Do you have any questions?
Yeah, I actually do have a question. So what if we look at the slides and we actually find an infarct?
So if you find an infarct or any other, histologic lesions, we'll generally come back to the heart, reevaluate, probably take some more sections, and we keep the organs in formalin for an extended period of time. So we're able to do that. So.
Okay.
All right. So this has been the dissection of an autopsy heart. I hope this was helpful for learning how to do the dissection. And as you know, it is the #1 cause of death in the United States. So it is an important part of any type of postmortem examination. Thank you very much.